You're good.
My name is Ashley Ebersole, and I did my research, this is the title of my research, Rehabilitation Following an Ankle Open Reduction and Internal Fixation Operation in a Patient with Possible Decreased Bone Mineral Density from an Early Onset Autoimmune Connective Tissue Disorder, and it was a case study. This is a general overview of what we're going to talk about today. First is my clinical question, followed by patient history, surgical technique, rehabilitation, and then results. So my clinical question. Do autoimmune disorders cause decreased bone mineral density and make someone more prone to sustaining a fracture or fractures? And I'll explain how I came to this question a little bit later. So patient history. I worked with a 19-year-old female who's a student here at Emory and Henry. She's not an athlete. And she came to the athletic training room after she fractured her lateral malleolus sledding. And she actually had an oblique distal fibular fracture, which I put a picture of an oblique fracture right here. And her fibula was laterally displaced. And she described the mechanism of injury as a twisting motion. After she finished sledding, she stepped into a ditch and she went to get up and broke her fibula. So she had an open reduction internal fixation surgery, but this is also called ORIF, which is how I'll refer to it later. And she has a pretty unique medical history. She has a connective tissue autoimmune disorder or is seeing a rheumatologist for a potential one. And she also has a history of fainting. And she told me that when she was younger, she noticed that she had more episodes of fainting when she got closer to her menstrual cycle. So they've put her on a constant birth control so she's amenorrheic. She doesn't have periods. She's only had one in her entire life since she was 14, which is pretty interesting considering her condition. Also, she doesn't have any other history of any type of fractures or injuries to her body, but she has had herniated discs in her lumbar region before. So, surgical technique. What is open reduction internal fixation? Technically, open reduction internal fixation is an invasive surgical procedure used to reduce fractures and displacements. It's usually used for unstable displaced fractures like my patient had, especially if the talus is dislocated. It can also be used for specific fractures such as trimalleolar, bimalleolar, and lateral malleolus fractures, which this picture is a picture of bimalleolar because it's the lateral malleolus and the medial malleolus. But trimalleolar also includes a distal tibial fracture in the posterior portion of the tibia. So some advantages and disadvantages of this surgery. With this surgery, the incision site is usually directly over the fracture. My patient's incision was right over her lateral malleolus because that's where her fracture was. So this gives the doctor direct inspection as well as access to the fracture. And research suggests that ORIF can usually improve wound healing and promote early mobilization and rehabilitation because of this direct access to the fracture site. Also, research that I found notes that ORIF leads to good functional outcomes, as well as shorter hospital stays and less joint stiffness than conservative treatment would. So some disadvantages or reasons why you wouldn't use ORIF would be if there's not enough soft tissue to cover the metalwork, because the metalwork for this type of surgery is pretty substantial, as you can see from this buttress plate. And depending on the type of fracture, there might be a bigger buttress plate, a smaller one, more screws, less screws, and even mesh and different wiring to fix these fractures. So some complications that you can have with any surgery, really. There's a chance of malunions, non-unions, infection, deep vein thrombosis, compartment syndrome, and necrosis. So those are some things to keep in mind when deciding if you want to have this surgery or not, or if it's right for you. Despite these risks, research that I found suggests that complication rates are lower with ORIF than they would be for external fixation. And also, there's some controversy on how long to wait. So if you sustain the fracture, should you wait 2 weeks before you have the surgery, or should you have surgery right away? And from what I found, that's usually surgeon preference, but it's also, if the person has a ton of swelling, they'll usually wait a couple of weeks to perform the surgery instead of doing it right away. But like I said, it's whatever the surgeon wants to do, pretty much. Also with this technique, like I mentioned about the plates, the metalwork and the technique varies from injury to injury depending on what type of fracture the person sustained. Like since this fracture is bimalleolar, there's going to be screws on the medial and lateral malleolus, but my patient only has a plate and screws on her lateral malleolus because that's where her fracture was. Also, the incision site will change as well, depending on the type of fracture. So a little bit about my rehabilitation for this patient. I put the goals on each slide, so I'm not going to read each one, but I am going to talk about some exercises that I did to reach these goals in each of the phases of the rehabilitation. So for the first phase, even though my patient came to the training room 2 months post-operation, she was set back a lot. She had a lot of swelling, she didn't have very good range of motion, she hadn't walked on her foot or done any type of exercises, she still had the boot and her crutch. So we had to start in phase 1 even though she was 2 months out of surgery. So we did a lot of towel stretching, passive towel stretching for dorsiflexion and plantar flexion, as well as marble pickups and seated BAPS forward. And I also did a gentle massage over her scar because it was really sensitive and it was really red and raised. So even though she had waited so long for rehabilitation, she did progress quickly through phase 1 because her swelling and her pain had decreased greatly after 1 week of rehabilitation. For phase 2, we continued into phase 2, and we continued the towel stretches that we were doing, as well as we added active dorsiflexion and plantar flexion activities like ankle pumps, and we also started working on double leg balance, taking her boot off and working on just standing, because her leg wasn't used to holding all of her weight because it hadn't done it in so long. She stopped using her crutch after 2 weeks, which was really good because she was kind of dependent on it, and we started to have to work on hip adduction and internal rotation exercises because the boot was so heavy for her body type. She started walking with an antalgic gait, her leg was externally rotated, and she kind of drug her foot along. So I really wanted to incorporate some of these hip exercises to make sure that it didn't hold her back from walking when she was ready to. So the next 2 phases, we kind of had to combine these because halfway through my patient told me that she was going to study abroad after school was going to end, and that was pretty close to what the end of my rehabilitation would have been. So I had to kind of condense these 2 phases and make them into one. So after 3 weeks she lost the boot, which was awesome because it was really causing problems with her walking. And we continued the BAPS exercises as well as double leg balance, and we started doing balance on the AirX pad. And we also did can-do band range of motion exercises for ankle dorsiflexion, plantar flexion, inversion, and eversion. And then I added a pull workout because the patient was really hesitant to walk without her boot with just her body. So adding the pull workouts really helped her she really gained confidence in trying to walk because it took some of her weight away and added buoyancy. So we did a lot of pull walking where she focused on walking heel to toe instead of with her foot externally rotated. And we did calf raises, squats in the pool, high knees in the pool, and we continued the hip exercises that I had implemented before. So this is a chart of my findings. These are the measurements that I did throughout her rehabilitation. I did one in April, which was before I started rehabilitation, April 20th, which was halfway through pretty much, and then May 5th, which was after the rehabilitation had ended. And in each of the columns, she made progress from beginning to end for each of the motions that I tested, as well as the girth, which I was really excited about. The next thing that I measured was her bone density, which ties back into my clinical question, do autoimmune disorders cause decreased bone mineral density? So a gentleman at Johnson Memorial Hospital in the radiology department had this machine, and it's basically an ultrasound machine, but you put your foot in this little space here, and then 2 arms come out with ultrasound gel from here, and then another spot over here, and it measures the bone density of your calcaneus. So we did this for her to see what her bone mineral density would be. And results of that, she measured in the T-score range of -0.8, which is here, which is technically in the normal range for bone density, but she's approaching the osteopenic level, and she's 19 years old, which is not very good. And just to give you kind of something to base this off of, I measured my bone density, and mine was -0.4. So in conclusion, before the discussion, my rehab was successful because it increased her range of motion and helped her return to an ambulatory state. But as far as my clinical question, her T-score approached the osteopenic range, which is very concerning for her age, like I said. But most of the research that I found supports the idea that bone density problems are only seen in older people, and especially in people that are women that are postmenopausal, not women that are 19 years old. But I came to the conclusion that I can't say that she has decreased bone density because of her autoimmune disorder. First of all, because she didn't fall into the osteopenic range, she's still in the normal range. And second of all, because there's so many other factors that can influence bone health, like vitamin deficiencies, hormone imbalances, and other conditions like Marfan syndrome, rickets, and other things that could cause decreased bone mineral density. And I never had a true diagnosis of what her connective tissue autoimmune disorder was. We just had there was just a general consensus with her rheumatologist that she was suffering from an autoimmune disorder. I think ways to improve this study, I really wish I could have had access to a DEXA scan, bone scan, because that would have given me an overall reading of her bone mineral density instead of one bone, because one bone doesn't really give me enough to say that she has decreased bone density at all. And also I think more research needs to be done looking at autoimmune disorders and how all these other factors like vitamin deficiencies and hormone imbalances play together as one, because I really didn't find any information on that. It was just different articles on the different aspects of my study, not linking them all together. So does anybody have any questions?
How does someone decide to use an ORIF over conservative treatment?
I'm glad you asked that, Blakely. What I found in my research was that there's certain goals that somebody has to meet before they can qualify for surgery or not, or have conservative treatment. And the 3 goals that they listed were there has to be an anatomical reduction, a successful anatomical reduction, early mobilization, and functional rehabilitation. If the patient can't meet those goals with conservative treatment, then surgery has to be considered. So they can't just have conservative treatment because they want it. If they don't meet any of these goals, or if these goals can't be met with conservative treatment, then you have to consider surgery or surgery or any type of surgery. Any other questions? Yes, sir.
Did you look in to see what effect birth control pills may have on bone density?
I did not. That's something that I wish I would have looked into, but I didn't actually know about her taking birth control pills until later into my research, later into the study. When we went to have her bone mineral density tested, I started asking her a lot more questions about her personal history, and I didn't find anything about estrogen deficiencies until later in the research, so I didn't really look at that.
Since she is on the osteopenic range of normal, are there any plans to try to up her bone mineral density in place right now?
Well, that's a good question too, but when we went with the gentleman who measured her bone density, she actually asked him that after we measured her bone density, and it was a lot lower than mine. She asked him if she should start taking calcium supplements or different things like that, and he said that with her medical history, it wouldn't be a good idea to just start taking it. There would need to be more of a comprehensive, a lot of her doctors sitting down talking about how this would affect her specifically. So I don't have any plans for it, but because she has such a wide range of medical problems, I think that that's something that she'll eventually need to think about, because she's 19 years old. So, and she has a lot of different issues, but not specifically for me.
Yeah.
So,
Just curious.
anybody else?
When you started her rehab, did her internal fixations, were they still present, or were they?
Yes, she still has all of her buttress plate and her screws. I think she had 7 screws and a buttress plate and some mesh wiring, but she didn't get them removed. And she said that her doctors told her if she did have problems with them, that she could get them removed, but they didn't advise it because I think she had some problems with healing to begin with. Her scar was still really raised and more like a keloid scar, so they didn't want to take them out unless they had to, but she still had them in when we did her rehab. Anybody else?